Good morning, everyone. Okay, I'm representing the mobile health contingent here. My background is in wireless networks, wireless sensor networks, and I spent many years bringing internet access to clinics and classrooms in remote parts of the world, such as rural Cambodia here. On those motorcycles, each one of those motorcycles has a Wi-Fi hotspot or access point, which is how we distributed the data around. This was in the pre-cell phone days. So one of my early projects and my first introduction to global health was actually applying this to telemedicine. And this was done through Partners Telemedicine, which was later called Center for Connected Health. So that's how I got into global health and started working in this field. And since then, we now apply phones for a variety of problems, including health diagnostics and now AI and machine learning. Global health is no stranger to technology. Over the years, even dating back to the 1960s, we've been using technologies such as radio, PCs, internet, and then more recently leading up to smartphones and AI. Those of you who work in this field may remember this type of phones, sort of the candy bar phones, and that led to some of the early pioneers in this field and companies such as Damagi, D-Tree, et cetera, Frontline SMS. We used to connect these to laptops and make our own SMS servers, and that led to systems such as the MAMA program, Bangladesh, the maternal health open data kit, and mapping things like Ushahidi platform. Then in 2007, we had the first iPhone, and that led us to the second generation of mHealth, which I call mHealth 2.0. So now we have smartphones that are being used around the world, and we're entering data into these phones. But if you think about it, how has the workflow actually changed? So 20 years ago, we were typing data into, or entering data into paper forms. Then when we had the web, we were manually entering data into web forms, and now we're manually entering data into mobile phones. But in some ways, the process has not changed. We're still using manual data entry, and there's a lot of errors and some falsification of the data. So now, fortunately, we're moving away from this and entering the next era in mHealth, which is, I call mHealth 3.0, where now we're really starting to use the capabilities of the phone. So we're adding intelligence, machine learning, and we're starting to also make use of all the full array of sensors that are built into the phone, which really augment human performance. So you can empower not only community health workers, but also GP doctors who are not specialists. The power of AI and the benefits of AI can be summed up in one way, as I have here on this plot. So you can look at the bottom axis is the cost, and the vertical axis is the skill required to use the tool. So in engineering, we often focus on the cost of a tool, but we don't often think about the skill that's required to use that tool. So I think what AI does is it lowers that threshold so that it makes the tool, low-cost tools, more accessible, and it lowers the burden to people who don't have that capability or that training. So we're now applying these principles to deploy a variety of platforms in health diagnostics, and even using other tools at the front end, such as using the camera to measure kids automatically, children and babies, to assess malnutrition, for example. As was discussed here, one of the big challenges in AI, even though the algorithms get most of the glory, a lot of work needs to be done at the front end. So how do you ensure the quality of that data? And I think there's a lot of opportunities here to clean up the data and make tools that will make the data easier to use and improve the quality, so you reduce the variance due to noise and other uses. So for example, here we have a tool which uses machine vision that automatically corrects for geometric distortion and parallax. It normalizes and scales the images, so you have nice, clean image data that can be imported directly into a machine learning algorithm without having to do any manual cleaning of the data. And we're applying this for urinalysis and other things. In terms of challenges, previous speakers have already talked about transparency and reproducibility challenges. There's many algorithms. Things like deep neural nets are notoriously not transparent. There's a lack of reproducibility. It's hard enough to reproduce results even within my own research group, let alone in clinics around the other side of the world. I'll tell you a very quick story. I think a bigger question is, how much intelligence do we use? So a couple of years ago, we created this nice questionnaire to diagnose pulmonary disease. And the way we implemented this is every After every question, we would recompute the model, and we would choose the feature that had the most predictive value, and we would ask that question. So in some cases, we can converge on a diagnosis with just 4 or 5 questions. And we deployed this, but it absolutely failed. Doctors thought it was a toy, that it didn't really work, and patients felt they were cheated because they came from far away, waited a long time in a waiting room, and to have something very quick and easy was actually surprising to them. So there's an optimum number of questions, an optimum amount of AI you want to include in your system. And there's also the notion of bias and fairness, which was addressed previously. And we currently, I'm part of a team at MIT that's funded by USAID looking at the notion of bias mitigation and also fairness in applying AI to these problems. If you want to see more information, there's a TED Talk on this famous example that came out a couple years ago from MIT, which showed how poorly face detection algorithms work if you're a black woman, for example. Lastly, I'm currently working on a project in collaboration with Harvard Medical School and Brigham and Women's, my collaborators in the audience. And we showed here that we've got very good results on predicting infections, on cesarean sections, and this is particularly for dark-skinned women. We know that in this case we have bias and it probably won't work on lighter-skinned women, but we're okay with that as long as you realize the limitations of your algorithm. So lastly, I think to summarize, AI has a lot of potential, but it needs to be used with care, and you need to understand what you're doing, and there's a lot of potential, particularly on the front end, to improve algorithms, to improve the quality of the data that goes into these algorithms. Thank you very much, and there's my contact information.
Intrigued by the ending note where you said, we have this algorithm to look at if C-sections are infected, and we know that it works well on darker colored women, and we're fine with that. We're fine self-limiting. I was wondering if you thought that there was any way to encourage kind of that more acceptance that the AI algorithm I've developed has its limits, and instead of letting me fall into the business pressures of overpromising that this can be applied very generally, to encourage developers to really say, this is the population that it specifically works on.
Sure. Just like we do for drugs, there's sort of prescribed use and then there's off-label use. I mean, we need to be transparent in when we give an algorithm to somebody, we need to say what it's good for and what it's not good for. And obviously, we're currently in a stage where there's a lot of misinformation about what AI and machine learning really are. And the expectations, as I showed you with the questionnaire with doctors and patients, there's huge expectations. People expect computers to be 100% correct, whereas even doctors are not 100% correct. So there's a lot of education that has to happen.